voy a moderar esta mañana. Les quiero dar a todos la bienvenida a este tercer curso de actualizaciones del Colegio Interamericano de Radiología, en colaboración con la Escuela Europea de Radiología. Estamos en el Salón Grand Coral 1 y vamos a presenciar el módulo de abdomen y urogenital que será el día de hoy y el día de mañana. Un importante aviso para todos ustedes: algunas de las sesiones, o la mayor parte de las sesiones, serán interactivas. Habrá una conferencia y después de la conferencia, de 20 o 30 minutos, habrá una sesión de preguntas. Para poder votar, deben bajar de su teléfono una aplicación que es CIR 2017. Se demora un minuto en bajar, la pueden bajar. Y CIR 2017, una vez que la bajen, deben actualizar el contenido y pinchar votaciones. Eso es todo. Y ahí aparecerán entonces las conferencias, aparecerá la conferencia del día y podrán entonces acceder al sistema de votación para que puedan participar de la sesión interactiva. En primer lugar, entonces, vamos a presenciar la conferencia Optimización de protocolos para resonancia abdominal, tiempo, calidad y Tesla, del profesor Yves Menu. El profesor Yves Menu es chairman de Servicio de Radiología de la Universidad de París 6. Ha sido presidente del Congreso Europeo de Radiología y es un gran especialista en resonancia magnética conocido por muchos de ustedes. Profesor.
Good morning to everybody. Thank you very much for the invitation to share with you my experience about the optimization of MRI of the abdomen, which is some difficult topic. But first of all, as you can see, you have to thank me also for bringing you the good weather. And this happens anytime I speak in a meeting, the weather is perfect. So next time you have an important family meeting or anything, please invite me and you're sure that the weather will be good. So what I'm going to tell you now is not guidelines, it's not a recommendation, it's only my experience as a radiologist, as a chairman who has to say to my co-workers what to do, and also as a manager who has to face many people who pay or not pay. So, why should we bother with the numbers, with the economy and the safety? This is not MRI, but this is our life. Numbers. Number one, what we observe is a significant difference in the length of the examination between university and private practice. The two departments are relatively separate in France. And as you can see, the same examination is done in 30 minutes average in the universities, 20 minutes in private facilities. Where is the difference? And obviously, the CT is much shorter than MRI. Can we improve the throughput of this MRI? It's important because our average waiting list is 35 days. 35 days, which is a lot. This goes to from 3 to 55, but the average is 35, and this is absolutely true in many European countries. For CT, there is no waiting list. If we have a lesson to learn from the liver transplantation, it is when we see a patient, we need to have the patient, we think the patient should be included in the waiting list. But anytime you put a patient in the waiting list, you put another one out of the waiting list. And this is important. And there was a very nice study from the Netherlands showing that putting a new patient in the waiting list was deleterious for the public health because the other one was taken out, and maybe this other one patient would have deserved transplantation. And this is the same when you have to manage waiting lists. Economy. The economy is very different from one country to another one, obviously. There are different rates of reimbursement. However, there is a common trait between all countries, and this is the one: cut costs, everywhere in the world. So what we have to do is to face our business plan, whether you like it or not. You have to face the people who want to make your examination much shorter. Administrators, they would like you to perform 100 examinations a day. Institutional customers, they would like you to be reimbursed in a very low level. But there are ups. The most terrible ups are my coworkers, because they keep on adding sequences and more sequences and sequences again, which is sometimes useful, but in many cases useless. And also our friends, the clinicians, who would appreciate to have any examination, anytime, immediately. So you have to do something. And I would like to show you also why you have to care with safety. Let me tell you this what happened in my hospital in 2012. I remember the day. A 43-year-old woman came. She had ultrasound for vague abdominal pain, and the ultrasound reported a small mass in the liver, not small, 10 centimeter, with some interior arterial signal. Well, this was looking a lot like a focal nodular hyperplasia, but in many cases, our colleague liked to open the umbrella and ask for something else. So we gave an appointment for, this is the tumor, we gave an appointment for MRI. There was no previous history, nothing. The protocol was very reasonable, T2, T1, dynamic series after injection. This was the first arterial phase, and the patient died 25 minutes later due to an anaphylactic shock. So was it normal to do this examination? Maybe not. So anytime you perform examination, anytime you perform an injection, you have to think about the safety. So your mission is to perform only the appropriate sequences, and also to consider that MRI is not a single block of the abdomen, but should be driven by the clinical information. So you need to lose time to have some time, choose the best T1, choose the best T2, choose the best DWI, and see if you need injection. So how do you lose time to earn time? Usually the radiologists don't take care about that. It's appointment. But you earn so much time giving appointment, and for instance detecting claustrophobia, instead of losing 10, 20, 30 minutes because the patient tries to get in, cannot get in, gets out, and you lose so much time. It's very easy to detect it. When giving an appointment, just ask, do you go in the elevators? If the answer is no, don't try to make MRI. If the answer is yes, maybe you can try, no problem. You need to get previous examination, this is important. You need to guide the initial choice for the good protocol, and you need to have pre-established protocol for clinical situation. And what is very important is to consider that the waiting room is a terrible place because the people look at each other. They are waiting for several machines. They do not understand why it's slow on one side, fast in the other side. They look at the other people, they are very sick, some people with tubes and everything, and say, well, where am I? Where am I? And therefore, I have closed my waiting room, closed. And now, because all my patients have mobile phones, they go to the cafeteria. Excepting for the MR enterography, they don't need to fast, so they can have a coffee, and we call them just for the examination. No more waiting rooms. Ensure that you get previous examinations. Look at this case. This is a patient with a follow-up for hepatocellular carcinoma treated with chemoembolization. We didn't know exactly what to think about it. So what is it? We don't know. But fortunately, we had the previous examination showing that this is a new lymph node. This is absolutely abnormal, and this was metastasis from the hepatocellular carcinoma. If you don't have the previous examination, what can you say? What can you say? Are you going to do a biopsy? Are you going to do a PET-CT? No, you will never know. Only comparison with the previous examination is worth. Patient installation. I'm always surprised to see that most of the failures in MRI are related to failure in the technique of the examination. You have to be sure, at least the technician has to be trained to put the patient right in the middle of the magnet and right in the middle of the useful field. I'll show you an image where it's not the case. The hands and shoulder should not touch the magnet. Just simply, if it's a new technician, are you sure that he knows where is the liver? Just ask them, and you will see that they will tell you that the liver is 10 centimeters lower than it is really. And take 1 minute to explain breath hold. It's 1 minute which is lost. It's 10 minutes which is improvement of the examination. Look at this patient. This patient was not in the right place, and the signal was very low in the lower part of the other liver. If you put back the patient in the correct position, look at this part of the liver where there was the only metastasis that would be seen. This is quite common. The examination, the machine tries to compensate, giving you a very nice image, but the nice image without the signal is not an image. So this is very, very important. T1. What should we do? Only the T1 Dixon modified. Now all the machines can do that. That provides you with 4 images, in phase, out phase, water, which is the fat suppression, and this one, which is free but useless. You don't need it. This patient had an angioma. As you can see, there is no difference between the different T1, and this patient had the liver cell adenoma, and as you can see, there is a signal drop here, mild signal drop with the fat saturation, and on fat sensitive image, the lesion is hyper intense. 15 seconds apnea, and this is enough for the T1. For the T2, you have usually 2 sequences. One is nice because it's very fast. You can do it with a breath hold, and it gives you something that looks like a T2, but it's not T2. It's very good for the differentiation of fluid versus which is not fluid. Conversely, the turbospin echo or fast spin echo, this is the same, is a lengthy sequence. It's respiratory gated, it takes minutes and minutes, ages, but we have an excellent low contrast resolution. Let me show the difference between these 2 sequences. On the left side, you have the single shot, which is called HAST on Siemens, a single shot on Siemens, Philips, and GE, which is very good for the differentiation of fluid and the rest. And on the right side, you have the turbospin echo. Look at this patient with multiple metastases of the liver. You don't see them because you don't have the contrast. With a low contrast tumor, you will not see them. And my friend Richard Barron used to call that the tumor suppressor sequences. So if you are looking for fluid, you can take the single shot. If you are looking for metastasis, tumors, don't use the single shot. This is important. This is another case, a patient with colon cancer and liver metastasis. What is that? This is probably an angioma. What is that? What is that? What is that? Look at the single shot. You can see the angioma and the another one, but you don't see anything else. On the turbospin echo, you can see the other tumor, which has low contrast tumor and metastasis. So once again, if you're looking for tumor for the detection, use the turbospin echo, not the HAST, not the single shot fast spin echo. Diffusion. Now we know it's not hype, it's not a toy, it's a tool, it's sometimes a killer. Certainly a tool. Look at this patient. This patient has a fluid-filled lesion and metastasis on T1 before and after injection. Look at the diffusion, B0, B200, B400, B800. You can see that the T2 shine-through phenomenon of the fluid shows you the decreasing intensity with the increasing B, while the tumor seems stabilized or even increasing. And the result, on the ADC, something that decreases in signal is white on the ADC map. This is more or less benign. Something which is more or less increasing or remains is black, and this is usually malignant. However, this is very good for detection. Now we know that for many metastases, diffusion-weighted imaging is the most sensitive sequence. However, conversely, it's not that good for the characterization, and we'll see an example a little bit later of the difficulties of diffusion to differentiate between benign and malignant lesion. There is no real threshold. Some people have claimed 1.6. No. I'm sure that with an ADC of 2, it's benign. With an ADC of 0.9, it's not benign, or it is an abscess. In between, I don't know. 1.2, 1.3, 1.4, I don't know. Look at the comparison between the T2 image and the diffusion. B0 provides you T2 image, not with the same resolution, but what you need is not resolution. What you need is contrast. BAT provides you with a restriction, showing you that this tumor has a malignant part in the periphery. And the ADC changes make the difference between the central necrosis and the tumor. So to some extension, the DWI can be a substitute for the T2 if it's good. It's not always that good. One case is not that good is hepatocellular carcinoma, because the ADC of the liver is not normal in cirrhosis. And therefore, the contrast in diffusion between hepatocellular carcinoma and the liver is not that good. I found interesting, nevertheless, a paper that was published in 2012 by a Korean team. And they said that, yes, okay, DWI is not extremely important. But if you are looking at liver nodules, cirrhotic nodules, a nodule with high intensity on DWI has more chance of growing and becoming HCC in the future. I don't know if it's true, I don't know if it's real, but it looks like, in this paper, it looks like quite interesting, showing the differences between different liver nodules. This is still work in progress. Dynamic study. You have to be aware now of the renal failure with reference to the nephrogenic sclerosis. And this is important. We don't see any more cases now because, number one, we have eliminated the linear contrast media, and second, because we check the renal function before we perform an examination. We do like with CT, we check the renal function in patient, let's say more than 70, or with any reason to have kidney failure. So this is important. We have not observed any more NSF for years now because of that. But please don't use anymore the linear chelates. And the linear chelates have another problem. You know that they go to the basal ganglia. We don't know for the moment if it is clinical problem, yes or no. But what is true now is that the recommendation is not to use the linear chelate of gadolinium and to use only the cyclic chelates of gadolinium. Well, this is the typical dynamic study. It shows you the arterial phase, something like 20-25 seconds. The portal phase at something like 70 seconds, showing here the wash-in, here the wash-out, as well as a capsule. You can perform late, delayed, equilibrium. I perform myself examination series at 2 minutes, not later, usually not later. And this gives you here the typical behavior of fibrosis. You can, of course, make more, but it's only a waste of time in many cases, because it will not provide you with more information. But what you can do sometimes is to use the liver-specific contrast media. There are two on the market, the Multihance and the Primovist Eovis, which are the twins. It's Primovist in Europe, Eovis in America. Advantages of this contrast are much higher parenchymal contrast that improve the detection rate. There are some merit in characterization, we'll see that later. Some limitation, number one, the cost. Number two, the time. You'll see that in a minute. It's not standard, but it is an option for selected cases. This is an example of a patient with hepatocellular carcinoma. The hepatobiliary phase shows that this lesion does not uptake the contrast media, but we don't need it really because we already have the wash-in, wash-out, and capsule, which show that this patient has a very typical hepatocellular carcinoma. This was the first cases published of a comparison between focal nodular hyperplasia and liver cell adenoma. This was published by Luigi Grazioli, and this patient was very kind to have both lesions on the same slice, which is very convenient for the presentation. So, what you see on the arterial phase is enhancement, and you cannot differentiate the two. At the hepatobiliary phase, this was with the Primovist, you can see that one is enhancing, and this is the focal nodular hyperplasia, and one is not enhancing, and this is the liver cell adenoma. Obviously, there are exceptions, but this is a rule we should keep in mind. What are the protocols? If you are using Primovist, it's a one-time protocol. You perform the T1, the injection immediately, and afterwards the T2, diffusion-weighted imaging, and the hepatobiliary phase starts at 20 minutes. And this is a big advantage of this contrast media. In total, the examination would not be more than 35 minutes. If you are using the Multihance, this is different. The first part is a very typical liver examination with the T1, with diffusion, with the T2, and the injection as usual. But you have to get the patient out of the machine and come back something like 90 minutes later and then perform one acquisition, T1, FATSAT, which is very short, but you have to get the patient again and to put it in the machine. So in total, it's 25 plus 10 minutes. It looks the same, but obviously having the patient right in the machine and keeping the patient in the machine is more simple than having the patient out and in again. Finally, I have 3 different protocols that I would like to share with you. And this would be clinically driven. The make it simple, the make it comprehensive, and the make it similar. When should you use the make it simple? It's characterization of something that you think is a cyst or an hemangioma. What should you do? Do you need all sequences? I can tell you that all patients have everything, excepting the liver-specific contrast media in many cases. But what you really need is T1, is T2, and probably diffusion-weighted imaging, and you don't always need gadolinium. This is a patient with a liver hemangioma. Liver hemangioma on fast Pineco, HAST. Both sequences show you that it is a liver hemangioma. This is diffusion. B0 shows you exactly the same information as the T2. And the B200, B800 shows you also the T2 shine through, showing that the ADC is high and that it is absolutely benign. So for such a tumor, you always need the T1. You can also have only the diffusion. Do we need the dynamic injection in order to have the famous enhancement of the angioma? Look at this patient. Look at that. This is the same patient I showed you before. This was a very typical hemangioma on diffusion. If you look at the dynamic series, you can see something like a fistula. This is complicated. Would you be sure that it is an angioma looking at that? And there are cases where this is difficult, and therefore injection is not necessary if you get the diagnosis without injection. The second protocol is the make it comprehensive, and this is adapted to the characterization of an unknown tumor. You have to do everything in that case. Or also if you want to stage a malignant tumor. In that case, all the session, all the lesions, all the sequences are necessary, excepting the single shot, Faspinico, which is the tumor suppressor sequence. You don't need it. Sometimes, not necessary initially, you need liver-specific contrast media, but everything is useful. And the third protocol, which is very important, is to make it similar. When you follow up a patient, please do not change the protocol. Do not change the protocol. Use exactly the same sequences that was used in the previous examination. Otherwise, different sequences, different machines, different radiologists make examination very difficult to compare. Take everything similar. Sequence, slide thickness, whitening, everything similar. And usually, the most standard are T1, T2, DW1, and T1 injection. Using these protocols, we have been able, in my department and in several hospitals, to improve 22% of the throughput. And this is important because we have the possibility to interleave some make it simple between two patients. Because the make it simple, you'll see, is very, very fast. And now, if we have a patient on ultrasound, maybe an angioma, we don't know, we go to MR immediately, without an appointment. Ask the patient, do you agree? Perform T1 and single shot or diffusion, and that's it. That's it. No problem. This is very reproducible. Look at this patient. This is a 39-year-old woman, an incidental liver lesion detected in my department, suggested hemangioma. This is a big hemangioma, but the radiologist wanted to have MRI due to very big size and heterogeneity. T1, as usual. T2, we have performed both the single shot and the Faspinico, which is completely stupid. And we have also performed the dynamic scans with arterial, portal, late. Okay, that's angioma. Wouldn't you say angioma without injection? Probably yes, you would. Saves time, saves risk, saves money. Get rid of the turbospinico, which is a lengthy. You get the T1, the single shot, and that's it. And this saves more time again. And the final examination is 7 minutes. And you can do that between two patients. So what we observe is that there are liver protocols are usually commonly fixed, always the same, and very mildly dependent on the clinical questions. And this explains that there is a very low variability in the duration of this examination. But please ask yourself, what is the added value of each sequence? Finally, what about Tesla? I have one 3T machine, one 1.5 machines. In my department, there are two groups. One group says only 3T. Another group says never 3T. What are the arguments? For the 3T Defender, obviously we have a higher signal. Maybe it's a better quality for T2 sequences. But the opponents, they would say that we have much more artifacts and we have a decreased T1 contrast. And everybody is right. And myself, I don't care. I take the patient either on the ET or on the 1.5. I know the strengths and weaknesses of each, but both can be useful for the examination of the patient. So in my view, for abdominal imaging, 3T is not necessary. But you can do on 3T without harm for the patient. Well, now I would like to show you a few cases in order to apply that. And let's say the first case is oily and rusted. This is a 42-year-old woman. She has a very severe overweight and abnormal liver test, as expected. Ultrasound shows frankly hyperechoic liver parenchyma and also a liver lesion on the left lobe. Here is the liver lesion. The liver lesion was isoechoic. It was seen only because it was extending a little bit beyond the limit of the liver. And what we know, I give you the result immediately. What we know from the biopsy is that there is a massive liver steatosis, which is evaluated at 50% by the pathologist. Okay? This is MR. Okay? In phase, out phase. And now I would like you to visually evaluate what, in your mind, you are not going to vote. Because if you are voting for that, you will not get the right answer. What is the fat fraction in this patient? Well, I remind you that the calculation of the fat fraction is signal in phase minus signal out phase divided by twice the signal in phase. I will help you. These are the values, 622, 618. So this is 4 divided by 1,200. And the result is virtually 0. There is a problem because we know that this patient has a 50% steatosis with pathology. Yes, the pathologist is stupid, but not to this point. And another problem is that if we look at the tumor itself, the tumor itself is white in phase and black out phase. And we knew that it was a mutated liver cell adenoma containing fat. Therefore, what is the reason why it works for the adenoma and it doesn't work for the parenchyma? So the explanation is quite easy, but you have to know it. For this reason, we now use the 6 to 11 echoes. I will show you the sequence that are provided by the vendor. This is for an example. The values of the echo time for GE and Siemens for the out phase, in phase, out phase, in phase, out phase, in phase images on the 6 echo sequence. As you can see, there are differences between the vendors. Don't try to change. Don't apply to Siemens the GE value. It will be catastrophic. Okay? And doing that, we will acquire the signal. Here is the normal signal. Out, in, out, in, out, in. Okay. If there is fat in the liver, the out phases will go down. The in phase will go up. Let's draw now a curve showing this very usual approach. If we draw a line through the in, a red line and a orange line through the out, the computer is able to calculate the difference between these two lines, and this is the fat fraction as calculated with a 6 echo sequence. If there is iron, things are different. Iron brings everything down, everything, without any change. And therefore, we don't have oscillations, we have only a decreasing curve. So now you have to learn where to look at. Can we see it? Yes. Somewhere on the image is hidden the echo time. The echo time on GE 1.5, in phase 4.17, out phase 2 point something. Okay, 2.8. This means that in the GE machine, the out phase was acquired before the in phase. But Mr. Siemens, with his 3 Tesla, he says, I am not able to register the first out phase echo, and I will wait until the second. But the second is the in phase, 2.46. It should have been there at 1.23 to get the first out phase. Impossible. And then he will measure the second out phase, not the first. This is important. Why is it important? Let's come back to our patient. I'm sure that you have all noticed that the spleen was black. In the background history of this patient, we knew that she had a leukemia, and she had many transfusions, and she has a very severe iron overload. And therefore, iron overload keeps the signal down. Steatosis oscillates. But if the out phase is done first, the in phase as a second will go down because of the iron, while the out phase will go down because of the fat. And you will see nothing because the iron and the fat will do the opposite on the signal, and you don't see any difference. So this is the addition of very severe fat deposition and iron deposition. You cannot do that, you cannot guess that on the Dixon 2 echoes technique. Impossible. You need many echoes, you need many different echoes. In this case, this is a GE, out phase is acquired first, and therefore iron is against fat. So before you draw any conclusion on a regular image, you have to identify the echo times of in phase and out phase. This is important. If the out phase is acquired after the in phase, just like Mr. Siemens does on his 3 Tesla, if there is a decrease of the signal, you do not know if it is related to fat because the out is down, or to iron because the out is after. If the opposed phase is acquired before the in phase, the absence of signal drop does not indicate the absence of steatosis. It may indicate that there is an equilibrium between iron and fat. This is a little bit complicated, but you have to get used to look at the echo times on the specific machine. And please, you have to check if the liver is not too black on T2. If it's too black on T2, think of iron. If the liver is not disappearing on DWI, if it disappears, iron. If the spleen is not white enough, because if the spleen is not white enough, this means that there is an iron deposition. Be careful, the spleen is very white in case of hemochromatosis because it does not put iron in the spleen. Transfusion would do that. So there is an interesting website. If you are lazy like me, you will not read too many papers about relaxometry and everything. You will just connect to the Yves Gandon's website. It provides you with a software which is called MR Quantif. Upload it. Upload also the appropriate sequence for your machine. Never buy the sequence from the vendor. It's much too expensive and absolutely useless, and provides you with column maps and nothing else. And this software will afterwards shows you the map of the decreased signal, just like I showed you. And if you are extremely lazy, it provides you with a report automatically. Okay? So I'm not telling you that this is the only method, but this is a method for lazy people like me. Okay, second, never marry a doctor. This is a 37-year-old woman with very vague abdominal pain. And this is because she married a doctor. She had liver test and ultrasound. Normal people would not. And obviously, we found mild elevation of CRP, some inflammation, and ultrasound shows multiple liver nodules, slightly hypoechoic. Okay? And what is the next step? Should be MR. Don't forget she's married a doctor, so this is CT. And CT shows multiple hypervascular lesions. Okay, multiple. I'm showing you a selection of the lesion at the arterial and the portal phase. Because CT was abnormal, we perform MR. Today, there are two good reasons to perform MR after CT. First, if CT is abnormal, to see what it is. Second, if CT is normal, to see that maybe MR would show something. So my opinion is to go directly to MR. So this is the MR. This is a busy slide, but it shows you the different planes. T2 doesn't show you anything excepting that it's not an angioma. In phase, out phase doesn't show you a lot. And after injection, you can see these two large tumors with something like this, with maybe a central scar in it, and down another level with a hypervascular multiple lesion with some return to the equilibrium, to the same level at the portal phase. So at this point, maybe you can vote a little bit. What is your best idea for this? Do you think it is likely to be multiple FNH, multinodular HCC, FNH plus adenoma, multiple adenoma, metastasis from neuroendocrine tumor? So, who would like to say? Cargando. This is a nice poll about one person. This is a good way. This is a good way to have the homogeneity. So let's come back to the presentation. Okay. So, well, probably it's multiple focal nodular hyperplasia. Can I show you the hepatobiliary phase? We used the multi-hands in this patient. And this is the late at 90 minutes. This is plain T1, and this is after. Does it change your mind? Yes, no? Probably no. Okay, there is an uptake. Okay. Let me show you another tumor. This is the first tumor, the left lobe, and this is the second one. Okay. In that case, the patient was not very nice with me because she has put the different tumor on different slices. So I have to show you several images, but obviously this one has a clear uptake of the contrast media, the liver specific, while this one does not. So we went for the biopsy of this lesion, and it was confirmed that it was liver cell adenoma, which was responsible for the elevation of the CRP. And the decision was, because it is smaller than 5 centimeters, not to do any surgery, but only surveillance. This was 3 years ago, and I had a follow-up last month, and this is absolutely similar. It has not changed a lot. So for the characterization, this is quite useful. May I remind you the different protocols? Unfortunately, in my country, we cannot have the Primovist, and we have to use the multi-hands, which is good, not as good as the Primovist, but is good anyway. But I have to tell you that both these media are linear, and they are under investigation by the European Medical Agency. And there is a first recommendation saying that maybe we should not use the multi-hands, and they would keep the Primovists only because there is no alternative. But both are linear and are subject to basal ganglia deposition. We'll see how it changes. Obviously, the Bracco company has made an attempt to change the decision, and what is important for us is that these contrast media are useful, but probably as a single shot. Don't use them in a recurrent manner. If you have to perform recurrent images, you need probably to go to cyclic contrast media. This is important, I think. Okay, so we have still some time. Can I show you that? Simple, if you know it. This is a 60-year-old man with a recent ascites and severe cholestasis. Ultrasound shows intrahepatic bile duct dilatation. There is no specific background for this patient. And what you can see that, and this is MRCP, and this is thin slices of MRCP. So, what can we see? On the T2 image, there is a nodular contour. This patient has probably cirrhosis. There is ascites, we knew that. There are portal systemic collaterals, probably long-standing portal hypertension. Splenomegaly, this is an old disease. And the common bile duct is very thin. So at this point, would you think of hyalocholangiocarcinoma, biliary cirrhosis, lymphangiostrucosis, peribiliary cyst, or Calorillis disease? Just think about a minute. Okay, made your mind? Okay. So, well, hyalocholangiocarcinoma is probably a good idea because when you say dilatation of intrahepatic bile ducts and thin common bile duct, this is the most common cause. But this is not the case here. Biliary cirrhosis, primary biliary cirrhosis is not a biliary disease, really, not of the large bile ducts. And secondary biliary cirrhosis would be consecutive to obstruction. Lymphangiostrucosis. Don't go on your mobile phone because this just does not exist. I needed a C. Okay? And obviously this is, you identify the peribiliary cyst at first glance. It cannot be a Calorillis disease because Calorillis disease will present with cystic disease, but much more peripheral. So this is very common in cirrhosis. This one is especially large. It always predominates, most prominent on the left side. On the left side, there is absolutely no disease of the bile duct. We don't know what it is. Is it a dilatation of the periductal gland? Is it ectasia of some lymphatics? We really don't know yet. This is another case with a very mild disease. It's not a disease. This is very common. We don't know it, but you have to learn how to identify that. And taking advantage of this case, I would like to show you something about MR cholangiography. There are two techniques, the 3D and the 2D. The 3D has many advantages. It's near isotropic image, near, not completely, near isotropic image. It's important because if you want to see the bile ducts, you need to have a coronal acquisition, the primary plane. If you want to see the pancreatic duct, it may be better to have the horizontal plane as the primary plane for acquisition. Even if you can do MIP, MPR afterwards, it's always better in the original primary plane. But it's near isotropic. It's high resolution. MIP and MPR are available, and there is an optimal signal to noise. But there are problems. The duration is high, and it depends on the respiratory rhythm of the patient. It needs patient participation. What is terrible are the patients who sleep in the machine. You know that 40% of the patients sleep if the examination is a little bit too long. And when they sleep, the respiratory rhythm is getting completely crazy. and you cannot get any more. You have to wait 1 minute before 2 cycles, and you have to waken the patient. Hey, wake up, please, breathe in. And it takes more reading time because there are thin slices and reconstruction. 2D method is very short. We have few artifacts. There is absolutely no need for post-processing because there is no possible post-processing. It allows also dynamic imaging. You can do it iteratively to see if the sphincter is opening, yes or no. You can therefore do repeated acquisition. It requires a breath hold, but there are fixed planes. So this, I do always 3D. But sometimes I have to say that 3D is difficult. These are 2 examples, 2 patients, patient left, patient right, with 3D and 2D. In this patient, the 3D is perfect. And the 2D is not bad, but not useful as compared with the 3D. But in this patient, it was not very cooperative, and we had to go back to the 2D in order to have some kind of useful image. So my opinion is that I always try to do a 3D, and the 2D for me is a plan B. Even in the same patient, look, 3D, 2D, 2017, 3D, 2D, 2016, 2017. This patient has a primary sclerosing cholangitis, and unfortunately, it's very difficult to compare the examination. 3D was perfect, 3D is terrible. Can you compare? Can you say anything about the evolution? Probably not. 2D was not that good, a little bit better, but still it's not extremely useful. Unfortunately, MR cholangiography is not optimal in all cases. But if you try the 3D, and in case of failure, go to 2D, I think you get the best combination. Don't forget that you always need to have T1 and T2 images in addition, because you need to look for the associated cases with biliary disease. Number 1, liver heterogeneity, which is very common in primary sclerosing cholangitis. Atrophy, localized atrophy, which is a sign of severity. Wall enhancement after injection of gadolinium of the bile duct wall. Perfusion changes, showing also, which are very common, and showing also that it is a severe disease. And for the stones, T2 obviously showing the black stones, and T1 showing in many cases the stones as white. So this is important to get these T1 and T2 images as well. Look at this patient. This patient was seen in emergency because of fever and pain, and he had a large gallbladder with a thickened wall. We were unsure about the presence or not of a stone in the gallbladder. But look what we see in the common bile duct. We can see something that looks a lot like a stone. This is geometric. See it again, see it again, see it again. There is nothing like a stone like this. This is only an artifact which goes from the top to the bottom of the common bile duct. So be careful with this central artifact, which is only a flow artifact in the bile duct, which is extremely common with the MR cholangiography, especially with 3D technique. Obviously, this 3D was good, and you don't see anything within the common bile duct. And this patient had a calculus cholecystitis. Do we have time for one more? Where is the moderator? No? Okay, we stop? Okay, so thank you very much for your attention.